I'm Sandy Blake. I'm the Director of Nursing at Wanganui District Health Board, for those that don't know me. And I'm also have been the lead for the national program with the Commission, which is probably in a way coming to its kind of end, the work that So it's a bit of a sad time for us really, because we've worked a very small team very closely together. I'll just move on to start off with Francis's quote, and we use this all the time, Francis, is the goal is to understand the older person's risks and plan with them, their families and their whānau to prevent falls in hospitals, residential care and in the community. And really it is all about the person who falls and their families, and we can never ever take that away from our minds. Just reminding you why we bothered. I guess in the first place the Minister at the time was a wee bit worried. Half of the harm from falls was from falls in hospital was worrying him on our national reporting, and he thought that we should do something about it. So hence that we started in hospitals. Although everybody told us for everyone in hospital, there's 30 odd in the community, and while we're focusing. So what I did at the time and with a colleague is we just looked around New Zealand DHBs to find out what was going on, and it was interesting, and you won't be surprised to know how many different risk assessments there were, all proclaiming to be evidence-based but being fixed up or changed or whatever, and truckloads of paperwork and no policies, and most of them were out of date actually, and procedures that didn't make sense. And I realised that, maybe we did have some work to do in hospitals after all, but it was really important that we did understand the bigger picture of our problem. And so we knew that from some work from Otago, good Otago, they come up all the time. We've got some people from Otago here today, but there was some work done from the university that says, well, look, if you invest in this problem, you will get returns. So that was sort of comforting for us, I guess, especially because we're spending public money. So the journey really was a journey of exploration, and I won't go through this now, but it actually needs the next piece put on it really now for 2016 to 17. But, I think one thing about it with all the patient safety campaigns and that we did raise the profile of the problem. And I think that's what you always got to do when you start. So falls became a focus for 2 patient safety campaigns. It just placed that spotlight on it, and our goal was always to promote strategies to address the problem. And really, and to be honest, when we started off, we had these goals and aims, but we were not sure how it was going to go because the evidence didn't support that too many things worked in the hospital environment to sustain improvement. So we did it by a number of ways really. That I became the clinical lead, and I visited a lot of places across New Zealand just talking about their perspective on the problem and what they were concentrating on. We did have Francis here in a previous seminar series, and I think these are very, very helpful and help us to think broader than our own little patch. We've had some webinars which have been successful. We always have a lot of people calling into our webinars. So there is a hunger still for the information. We've developed some partnerships. I know most people in the DHBs who lead falls across the country, so I have developed some relationships, and we've developed relationships with each other, which is still ongoing. Having some practical resources to use in the ward areas and the clinical areas and aged residential care is really, really helpful, because sometimes, we worry about bits of paper, and having some practical help has been very helpful in increasing the awareness. I think that the promotion of evidence in the beginning, the 10 topics, was fantastic. And I don't know whose idea that was to start with. Probably collectively it was our expert advisory group's decision, but that has been worth its weight in gold, because as been told by previous speakers, there's not a lot of change in the evidence, but hey, isn't it good to know that when we start something that we've got the recent evidence at our fingertips. And of course the April Fools, as Lorraine talks about. And we've had a lot of engagement with our April Fools, some funny things, some people dressing up, all sorts of ideas, dancing, but it's all about bringing that falls to the front of our minds. when I think about building a community of practice, and that's really what we're doing here today, and my colleagues that have spoken before me have all talked about that. For me, it's about leadership, and it is leadership at all areas, but for the program and the commission was leadership from an expert advisory group. And then that expertise gets reinforced by me as a clinical leader's visits, but also picked up by other clinical leaders in their areas. It's endorsed by both our local and international experts, so that we know that we're heading on a pathway similar to them, and have listened to their, when they've fallen in holes, but listened to the successes also. And I guess another big strong part for me, and I know that I come with a one-eyed nursing view sometimes, but professional groups such as the DONs and the Directors of Allied Health have got to own this problem. Because if we're just expecting people at the coalface to just get on and do it and manage it, and it's not our problem. So it's important to me, and it's so important to me, that if somebody gets harmed from a fall in my place, I know that if I'm at work, within 5 or 10 minutes after that, there's a knock on my door and somebody tells me personally. And I think of one clinical nurse manager, and it's a while ago now, because we're 2.5 years, except for one exception of a fractured hip in our mental health unit just recently, which I can tell you about shortly. We have not had a fractured hip in our place. So I remember the last one vividly, when Colleen, my clinical nurse manager of the medical ward, came and knocked on my door, and she had tears in her eyes. And I don't want them to cry about it, but I want them to feel it. I want them to feel the harm that patients suffer. We can never feel the harm the way the patients do, but and I was able to say to her, it's all right, we're going to learn from this one, and we'll just need to talk to the family now. And so it's really important that you have that leadership. And of course, we talk about adaptive models, but adaptive for those caring for older people. And look, we've developed a whole lot of resources, and you've seen plenty more from the UK and from Australia. And now we've got ACC have produced some wonderful stuff just of recent times. So the resources are there to help us to implement evidence-based strategies. And again, this is the 10 topics, but you know, we turned to the evidence and we developed the 10 topics so that we could support in a practical way implementation of those strategies. And I think that's quite important when you see the way we've changed the 10 topics now. If you haven't seen the new version, get online and have a look at the Health Quality and Safety Commission website, because these have been adapted so that somebody in aged residential care, somebody in private hospitals can pick them up and use them, and they're written in a way that you don't have to have a master's to understand them. I'm not saying the last lot were like that, but you want things that are easy to read, and patients and family can pick them up and read them as well. So I just ask you to look on board, because that's just been very recently updated, and I won't go through that. So the project aims, I guess, were always for us to reduce the, what did we measure? You can try to measure falls rates, but actually we know they're not accurate, and they're really hard to measure. So we chose that we would measure a couple of process measures and one outcome measure. And so our outcome measure, and we just took a punt at it. How did we know what we could reduce? We just made a guess, really, in a way, by looking at what other studies had said they'd managed to reduce. So that reduction of fractured hips in hospital. And then we wanted to make sure that everybody had some sort of, any older person that came into hospital had some sort of risk assessment done, but more importantly, had actions taken to mitigate the risks that were identified in the risk assessment. So, and then we knew that obviously the biggest work had to move to out into the community. And I know in my place in Wanganui that about 20% of the fractured hips that come in through the front door come from aged residential care. I know exactly how many come from my community as well. And I also know how many times the ambulance go out to people in my community. So that's the sort of information you need when you're thinking about the whole of your prevention strategy. And of course, you know, when you look at our triple aim in New Zealand, that we want it better for an individual older person, we want it better for a hospital or a care provider, but actually what we're aiming for is better for the whole community. And you look at this and you think, well, that's just fairly ordinary, really. But, the important thing about adaptive models is that you start where it makes sense to start. And you can start anywhere in here, really, and where you start will make a difference because your focus is on it now. So the evidence is provided for us. But, the risk assessment, I'm going to go through each of these in a moment, because I think in a care setting, in a practical sense, if you cover off these things, you're a long way. It's not the total answer, because you've got other things like your environment and all those other things. But actually, if you start here where it makes sense to start, I find that that's a helpful way to look at it. And when you look at risk assessment, we've heard a lot of people talking about that this morning, that we do have to move away from those predictive tools. And I know it because, interesting enough, the lady who fell last in our place and fractured her hip in mental health unit, and it's the first time in 8 years that acute mental health units ever had somebody fall and break a bone of any sort. So it was a big shock to them, But they don't routinely do any risk assessments for patients in that unit. You can imagine what's changed right as this minute it's changed. However, what was interesting to me, and it's no disrespect to the OT, but the OT actually had done a risk assessment. Now, this lady had already fallen 3 times, and the sensitivity of her tool was documented that the patient was at medium risk of falling. But she'd already fallen 3 times. So it talks about the sensitivity of tools. In the Central region, we've just done our care indicator survey, and we know that just as many people that are considered by using predictive tools, in some places still use them, particularly around, I use pressure injuries, for example, those that were considered at low risk of having a pressure injury using the Braden, and those that were at high risk, there was no difference. The same amount of people got pressure injuries. So that kind of gives you the bit of the lens on the predictive tools. So the level of risk is not important, low, moderate, high, whatever, but the actual person's risk is, and that is the difference. And so that's reinforced by the Commission getting us to do those measurements. Clinical judgment, my God, don't you wish that you could have confidence that this was happening all of the time? Wouldn't it be a wonderful thing? Being a director of nursing, it breaks my heart sometimes. But you want people to think, so you don't want to give them a care plan. They go tick, 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 tick. And one DHB I went to, the nurses just went tick and drew a line down to the end and ticked the last one. So that, you want them to think, this is the risk, what can I modify? I can't change the age, God, I wish we could, but you can change some things to take the risk. Essentials of care, this is the care that every patient should have, whether they're at risk of falling or not, and the only damn way you know it's been done is you audit it. So you want all beds at the right height for the patient so they sit around and their feet are flat on the ground. You want things in reach. You want that uncluttered view we saw earlier, not cluttered like that. But if you have stuff that you don't expect nurses or other allied health people to document, and it's a given, that given has to be taught and it has to be audited. And I've talked about the fact that individual patient strategies must inform what we do. And what I like about the individual strategies, I actually like my nurses to write them. I know I'm old-fashioned. But, most people will be covered by the essential elements of care that you give to everybody. But actually the 1 or 2 things that really matter for that person, I want them to write it because I want them to think about it. So I don't want them to just tick off a box. And so, look, the patient and family input, the whānau output, input, I can't talk strongly enough. I think if we did this the best of everything, actually this would be the strongest thing we could do. Because when our people with dementia and delirium come into our wards, the families know. So why do we have visiting hours that restrict families being by the beds all times, particularly for our elderly? We now have open visiting hours in our place, and what I love when I go into the area where the cognitive impaired people are kept, and we have cohort them down one end of a ward because it's safer down there, Families are there at 9 o'clock or 8 o'clock feeding them breakfast when I walk around. I mean, they're not going to fall with their loved ones next to them. And these cognitive impaired, which is usually 1/3 of the medical ward at any one time, wouldn't it be a leader? Any one time would be 1/3 of the people that have got cognitive impaired in that medical ward. None of them have fallen in 2.5 years and broken anything. So that talks about a close model of care for those people, and having the family in the plan. And that's, I really can't say too much about that the family and the patient, when they are able, need to be with us at all times in our thinking about what will work. This close care for cognitive impaired, if I hear the word watching, I just about go into an apoplectic fit. And it's not about watching. It's about, if you think about a person when they're really unwell in intensive care, they need a one-on-one, and as they get a bit better and, their circles of care spread out. If you think about somebody with dementia, why do we treat them any differently? Lorraine's point. And for us, it's sometimes it's one-to-one, but actually often it's one in a 4-bedded bay, but that person in there is eyes on at all times. They don't go behind a curtain and not see the other people in the room. But more importantly, the most important thing is they connect with the person. Because once you work out something about that cognitive impaired person, and the family help you with that, and the carers help you, and you can have some sort of connection and find out what keeps them calm, they're not going to get agitated, they're not going to be climbing over bedrolls, and they're not going to be pacing and disappearing. So it's about close care of those with cognitive impairment. And we've talked about the evidence, and I'm no academic, I have no academic claim to fame at all, not like my colleagues here, but I know that I need the evidence to guide me and help me get on the right track. The measures I've talked about, and we have a lot of people say, well, why do we keep on measuring the same old thing? It actually doesn't matter what you measure, really, as long as people realise that measurement has to do with falls, and the falls is important to the Director of Nursing, it's important to the CEO, and it's important to the board, and you report accordingly. And so when we all own the problem, we all want to know how we're going against it. And we've got the atlas here, which is really, really good for us. But it's about a whole of system. Now, you can't see this very well, and this is the Wanganui Falls Plan. We started with it all red. It's got every component of evidence that we could think of at the time. We've just added in now the strength and balance exercises on number 17 for that we're going to do with the ACC for the frail and elderly at home. But you can't look at hospital falls reduction without the whole of the system, because they're only in hospital, 2.5 days sometimes, 3 days. Then they're out into the community. So your fracture liaison, your falls prevention nurse, your whole centre point of entry into hospital plan needs to be. And we just do this because obviously there's a plan behind every piece. You can see we've got hip fracture registry in there, we've got medications in there, we've got strength and balance in there. But look, it's the whole of picture idea. And no matter where you are, age residential care in there, you sit where you do, but you can't not see the rest of the picture and know what's going on. And Lorraine's work about how many people in your town are doing strength and balance exercises and things, which we talked about. So just in finishing up, have we made a difference? Well, we have made a difference, but I'm forever concerned that we take our mind off the problem, and the fractured knobs go up in hospitals again. But we definitely have made a difference. There's our latest stuff coming down through to March, 2017. We had a bit of a nervous quiver there where we went a few points above the line, but overall we're trending down. But this is as good as we keep a focus on in the hospitals, because the people in our community have still got poor bone health. And it's going to take a couple of generations now of doing the work we're doing with strength and balance, with medications and that, to make the bones strong. So when they're coming into our hospital, the best way that we can do is keep them off the floor, because when they hit the floor, they are likely to break still. So I think the figures the Commission have got, I think we're just about to release a report from the Commission. We're down to 77 fractured NOFs, I think it is. I might be just slightly out, a figure or two out on that while they're reconciling. But we've had another drop. So, I just hold my breath, really. I can never forget that every one of those people that fall, the 77, the 80, whatever they are, the 2,500 in the UK, are loved by somebody. They're a part of a family. They're part that we should feel a bit of pain, but gee, the families feel a lot more pain. And we take away people's independence. They end up places they don't want to be. And I think we've got to hold that in our mind. And Richard's done some wonderful work in the Commission. It says it costs us a lot of money in robbed years and healthy living time. And so it robs people of life, and that is true. So, we've got to carry on leading. We've got to keep somehow, with the Commission's shrinking their view and ACC picking up a lot more, but we've got to sustain the focus in the hospital as well as the other places, because if we take our mind off it, I am sure that we will get sloppy like we do and we move on to something else. And so we've got to sustain it. We've got to keep measuring, because if we don't measure, we don't know. But we don't have to measure a lot, but we have to measure what matters. We must keep learning and educating, and this is why the Commission are going to keep updating the evidence for us every 3 years or so. We keep doing April Fools, and let's all try and do something next April. And that cross-agency, which is going to be talked about next, is kind of the way of the future. So when we talk about figures in that, but 217,000 people aged 50 and over had an ACC claim for a fall-related injury in 2015. So they're our insurers, so you can ensure that we will let the ACC know. So we've got a huge, our figures are huge there as well, and 3,600 aged 50 plus were admitted with a fracture due to a fall in 2015. So, and half of our fractures, of course, are in over those 85, and 2/3 of them are in women. So it's just a word of caution. We must not take our focus away, take our eye off the problem. We must look on the whole of system approach, and we've got to think about that with planning and funding and how we fund things into the community. But sadly, the problem probably is not ever going to go away, because we're individuals, we're prone to error, we're prone to fall, we're prone to bad health. So that's not going to go away. So I'll just finish there, that we just keep working together to improve outcomes for older people and enable a falls and fracture system for the future. Thank you very much.